Thank you to the SAGE's program committee, and thanks to the moderators for having us, allowing us the opportunity to present our work today. It's a combined effort of the Department of Epidemiology, the Department of Community Health, and my department, the Department of Surgery at SUNY Buffalo. We have no disclosures relevant to the talk. CDC data reveals about 40% of the U.S. population is obese. It's been well described previously that obesity-related comorbidities are well described, and bariatric surgery has been proven to be the most effective therapy for the morbidly obese and their comorbidities. With bariatric surgery, there's a potential savings of $500 billion by the well-described improvements in diabetes, obstructive sleep apnea, hyperlipidemia, hypertension, and premature death. Nationally, the census shows us that African American women and men, as being a minority, represent about 12% of the population, with white men and white women being approximately 35% of the population. However, African Americans bear disproportionate burdens of obesity, and we find that those populations tend to be heavier and sicker. Among African Americans versus whites, there is a 1 to 2-fold increase in comorbidities given obesity and type 2 diabetes, hypertension, end-stage renal disease with dialysis. Looking at NHDS data from 1999 to 2010, you can see that the number of inpatient discharges for metabolic and bariatric surgery per 1,000 eligible adults is clearly, and this is my experience as a bariatric surgeon, women outnumber men 8 to 2. However, when it's broken down by race, you can see very clearly that white women utilize bariatric surgery much more than African American women, and of course, more than white men. But even more importantly and obvious in looking at the data are that African American men utilize bariatric surgery the least. Previous studies prior to 2010 have identified that the most influential barrier is access to insurance coverage. Interestingly, with the advent of the ACA and the decreasing numbers of uninsured, would have been predicted that bariatric surgery would increase through increased access. As a result of the ACA, 23 states now cover metabolic and bariatric surgery. Medicare covers bariatric procedures. Medicaid coverage has increased dramatically for bariatric surgery, and bariatric surgery for diabetic patients in some states is now available. Our current study goals include utilizing a national registry for metabolic and bariatric surgery, MSQIP, and in those procedures we aim to estimate the utilization of metabolic and bariatric surgery by gender and race, and to identify previously overlooked factors driving disparities in access to metabolic and bariatric surgery. As you know, the combination of forces between the ACS and ASMBS produced MSQIP. And in 2015, the participant use data file was examined. It takes data from 805 U.S. hospitals, capturing 90% of all bariatric procedures in the country. Some, of course, are performed at the freestanding ambulatory centers. And, of course, the data is de-identified at the patient, hospital, and region level, and it's aggregated. We combined the main file, BMI file, and the 3 intervention files, including readmission, reoperation, and intervention. We excluded in the database invalid ages, BMIs. We took out women and men of other races, which revealed a final analysis data set with white and African American men with an N of 30,000. Patients who underwent metabolic and bariatric surgery, 80% as well known as women, 20% men, but among the men, only 11% were represented by African American men. What this reveals is a striking and unique demographic that African American men only account for 2.2% of those undergoing metabolic and bariatric surgery, while in the population they represent over 20% of obese patients. African American men tend to be younger, but sicker, having higher rates of diabetes, hypertension, and 2 to 5 times as much renal insufficiency and dialysis, with an ASA class at presentation, despite being younger, being higher. Compared to white men, African American men had a 47% higher odds of having a hospital stay greater than 4 days, and 24% higher odds of having postoperative complications. Phase 1 of the project took the quantitative results from our analysis and attempted to validate the findings in Phase 2, where we interviewed minority patient ambassadors in group interviews in Buffalo. We took their responses, statements, thoughts, and opinions, and tried to establish some qualitative findings, which hopefully could generate explanations, hypotheses, and lead to more investigations. Our focus group questions included: how do African American men perceive obesity? Do African American men relate their chronic diseases to their obesity? Would African American men be willing to consider bariatric surgery to manage their chronic diseases? And in your opinion, what would the potential barriers among African American men to undergo bariatric surgery if they are eligible medically for the procedure? Finding 1 was that African American men do not relate their chronic diseases with their obesity, and in most instances consider surgery only as a last resort in life and death situations. That's considered a patient-level barrier. Finding 2 was African American men, especially young men, often do not have health insurance and a regular primary physician. As a system-level barrier, despite the ACA and increasing coverage, African American men still did not find a regular source of primary care, especially in comparison to their white cohorts. Finding 3, physicians do not communicate well that weight contributes to overall health and wellness with African American patients. Some of them mentioned that doctors either don't bring up bariatric surgery, don't help them access bariatric surgery, or do not explain it well. So in conclusion, obese African American men are sicker than obese whites, given the same weight and even younger age, and need metabolic surgery earlier. The ACA has not increased metabolic and bariatric surgery access for African American men, despite PCP and patient-level barriers. Larger studies of obese African American men and their perceptions are needed to understand and overcome barriers. And phase 3 of our planned research will be to actually try to implement outreach programs to the African American male community. Thank you.